But what concerns me about the massive online telehealth that's exploding, a lot of it lacks any kind of patient interaction with the provider. I mean, anything meaningful. And so that's what really worries me, because there's not necessarily enough focus on the holistic person and their entire health and their healthcare team and who this person is as an individual.
Yeah, not only are you not face-to-face, but they never even meet in some cases, right?
Yes, in some cases, there's a healthcare provider behind the scenes that's approving prescriptions, and everything else is done through questionnaires or bots, basically. And so it gives the impression to the person filling out the questionnaires that there is some provider interaction of some type, but it's very impersonal and there really isn't someone at that level of responsibility monitoring or obtaining the data, asking follow-up questions. Follow-up questions are the key to good medicine.
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Howdy.
Hello.
Hi.
All right, on the show this week, we're talking about the rise of telehealth when it comes to treating metabolic issues. This is a huge new emerging market connecting patients with groundbreaking drugs that are helping in the fight against obesity and diabetes and all these other medical issues. So, Dr. Cooper, I guess what we need to do to start our conversation is to really just set a baseline for where we are in the delivery of telehealth, because until the pandemic, it really wasn't a thing, was it?
It was really very, very rare to have telehealth appointments. In fact, the platforms for telehealth were very weak and, didn't really work very well. And then with the pandemic hitting us, we saw just a huge need for telehealth. I mean, overnight. And so everything from Zoom, was trying to be adapted to these medical programs that are HIPAA compliant and geared to medical visits, were adapted to integrate with electronic medical records. And before we knew it, telehealth was kind of just a normal thing that people did. And as we went through the next few years, we found that both providers and patients really like telehealth, actually. So it has really stuck. And part of that is it's really hard to go back to the old way of doing things once you've made that transition. Just logistically within medical clinics and medical settings, it's hard to do these hybrid or go from having completely transformed to a telehealth practice going back to the in-person. It's pretty tough. But there's so many advantages really to telehealth for patients and providers.
Yeah. You and I are in the Seattle area and traffic here is just terrible.
Yeah.
So going to telehealth really does save, an hour and a half in traffic when you think about all the time it takes to get to and from just the appointment. So I've been loving telehealth. Let's talk about some of the pitfalls of telehealth, because the larger discussion that we're going to have is that more and more people, in a good way, are getting connected with these medications like GLP-1s, but there's a bit of a disconnect when it comes to providing actual medical care in the traditional sense. The relationship that's involved, the time spent face-to-face that's involved to get to know the patient and their unique medical history. So let's open that up a little bit, and then we'll take a deep dive.
Yeah, it's really hard to get your head around some of this stuff because on one hand, some of the research is showing that AI in medicine is very good. And in some ways, in many settings, it's better than the human doctor making the decisions, which is kind of astonishing. But I think that we're not there yet, and I really feel like, especially when it comes to metabolic health involves so many aspects of your entire medical condition. It's just so risky to enter into some of these telehealth programs that are very impersonal, where there may not even be much interaction, if any, with an actual healthcare professional at the level of a doctor or nurse practitioner or even a physician assistant. So, and one of the main reasons is that when we make decisions about patients as providers, it's a big process. The decision making for just one visit is a big process that you go through, because the first step is you have to take in information from the patient. How is the patient doing? That's called the history. And you can learn an awful lot from just questioning someone about things and then listening to what they say, then coming back with these follow-up questions that dig deeper into the issue. And also reviewing their history of what happened at the interval between when you saw them before. Did they see a specialist? Did they have surgery? Did anything change with their medication? I mean, there's just so much detail to go over before you're even ready to make a decision of any kind. So you've got to get that info from the patient. Then the provider has to look over the medical history, not just the maybe lab work the patient has done between the last time the provider saw them and the current, but also the history of their labs over time and the history of their progress and different data points and their medical record, what kind of visit notes are coming from other outside providers, cardiology, nephrology, neurology, all of that needs to be looked at. And any changes in medications, supplements from outside providers, not just your own medications. So there's so much information that is very important. Yes, you could use questionnaires for it, but most often it's not enough, because to design a questionnaire that asks every possible question you'd want and the follow-up questions, that's not going to happen. I mean, the normal course of a conversation is so much more natural to be able to figure out and follow the little clues. And so, again, medicine's like that Sherlock Holmes, it's investigative. And probably a lot like you, Mark, with your profession, well, you're not an investigative reporter, but reporters and journalists are always trying to find, these follow-up questions and the real answers. And so that's how that relationship should be. And so you think about that, that's a lot before you even get to where, okay, let's figure out this assessment. This is what we think is going on at the situation. This is what we think is the plan, the proper plan and strategy to move forward. And often providers are not just thinking of that plan, but they're thinking of a plan B, a plan C, in case there's issues with, say, access to medication, or in case there's issues with tolerance to medication. They're already kind of thinking in their mind, if this isn't working, maybe we could go this direction. They're also thinking next steps. So next time, what kind of labs do we want to do for a follow-up? Do we need to do any more referrals? I'm just laying this out just so that the person understands that the medical visit and what a doctor or a healthcare provider's role is, and what the patient's role is. Of course, the patient has the responsibility to relay the information, but they shouldn't have to worry about micromanaging their care. That's something that their provider is supposed to help with. So getting back to your question, the concern with some of the rise in the telehealth that's been so kind of like snap at your fingertips, like just making it so immediate gratification, that isn't what most qualified medical professionals see as actual medical care. And that is concerning to medical providers to see that level of widespread use of something that's often really superficial and just not thorough enough, and quick to prescribe, and very little objective information such as lab work, and all of the objective information is actually just what a patient would say on the website and the questionnaires. And none of it has been really verified in any way. So these are just the concerns. Now, that's not to say that there aren't reputable telehealth companies that are addressing obesity. There are. But I just think that the listeners should be aware that it's not all apples to apples.
I think some of these so-called telehealth companies are more like telesymptom companies, because they're dealing with just one thing. Like they're dealing with, call me, get GLP. Call me, get erectile dysfunction medicine. Call me, get this. They're not dealing with health, like overall health. Like for me personally, I want a doctor who knows my whole body. I want a primary care physician, or I want a physician like you, Dr. Cooper, who understands my whole body. My metabolic problem was a big, messy puzzle. It was a problem that was an entirety. It wasn't something that was just one problem. It was, like you said, it was something that a detective needed to have happen. Like, there was a lot of mess, and there was a lot of broken things going on. And it wasn't something that could be handled really with just like fill out this questionnaire A, B, C, D, because there was a plan A, plan B, plan C, plan this. I mean, we've gone through a lot of plans. And I don't think it was something that could be filled out on a piece of paper. So while I think that it's not transactional for me. I don't think my health is transactional. I think of my health as something that is all-encompassing. And for me personally, I need somebody who can look at the whole picture, not just one little slice of the pie under my arm or something. You know, like I want somebody who can connect all the dots. And I think that people are starting to look at, they're confusing medicine with a symptom or something. It's very confusing to me, and it's almost like you want a quick fix as opposed to healing.
Yeah. What's interesting, Dr. Cooper, is that in some of these telehealth scenarios, you fill out the questionnaire online. You never meet the medical provider, the person signing the prescription, authorizing the prescription, and they send you the drugs in the mail. And I'm just thinking, how come there's not a requirement that you there should be a requirement, I think, to have a connection between the patient and the doctor. But, well, I'm going to call you out. You did a little sleuthing last night. You posed as a patient. I don't think this is unethical. You were just trying to get some information. But tell us what happened there.
Well, I just couldn't believe that it was as easy as people were saying to just log in or go on to websites. I probably shouldn't say the name of these.
Right, but this is to get GLP-1s, right?
To get, it's like the advertisements that you constantly see. GLP-1, get help for obesity or whatever. So I clicked on it, and it took me to some questions, and then I passed those because I made sure that my weight and height put me at BMI of 31. It was 31. So,
which is on the low side.
Well, you have to be at 30 or higher. I mean, right. I didn't try it at a lower BMI. I could try that and see if it goes through, but I figured to give them credit that they're not going to prescribe if I'm not in the FDA range.
Right. So you were just a little chubby.
So I put that, my height and weight, and then I answered the questions. There were not very many questions related to health. I mean, there were some major ones like, have you had a heart attack, diabetes, things like that. And then surgery was really the only questions for surgery were about bariatric surgeries. And then there were questions like, what's important to you? The cost of the medicine, low side effects. It was just kind of that, or a personalized, they use the term personalized a lot, but their idea of personalized was they were going to give a personalized medication, like ramping up plan kind of thing. So is that important to you to have the personalized plan? So using that word personalized seemed really manipulative too. Because it was so obvious this was like a bot and it wasn't personal at all. So I think the word was to try to make you feel like it's personal or that there was something personal about it. So anyway, I went through all that and all these questions, and then it quickly flashed to me, oh, you're a candidate. They showed a chart where my BMI was in the optimal range for the GLP-1s, and
winner.
Yeah, like I'm a winner, right? It was green, and then it said it went straight to the compounded semaglutide, which I was kind of confused because I thought they're not able to do that anymore. But it went to the compounded semaglutide, both either the injection or the pills. And that might have been because I said I wanted the cost as a barrier. So they gave me the compounded as the first primary option. Then they said, view more options. And I clicked that. And then it had this whole array of like every medicine you've ever heard of that's used for weight loss. Like a menu kind of you would have if you went to like a ice cream shop or something. And you could just pick, and some of it was like a kit that comes with anti-nausea medicine too. And it showed the prices and all that, like a pick and choose kind of thing. And then it was like, okay, your provider is reviewing and will have your prescription or something.
Wow. Did it ask about your blood pressure or cholesterol or anything like that? Any of the other benchmarks?
It asked if you have high cholesterol, and then it didn't ask your specific blood pressure at all. It just asked if you have hypertension. So that would be like a big concern because so many of our patients don't think they have hypertension or even diabetes, and it turns out they do. Mm-hmm. They don't know. How would they know? I mean, there was no like upload your labs or go to the lab next and check your numbers, nothing like that. So I really was really surprised because I think people give these telehealth businesses a lot more credit than they deserve because people in the field, like, you have to keep in mind, people see dollar signs. There's huge investors in this field now trying to figure out this magic of how to make the most money out of this. And some of them, unfortunately, are doctors too. And they are linking up with tech people trying to figure out this AI around how you do this. Now, I'm not saying, there are definitely well-intended people in that area that are trying to do this in a responsible manner. But I think it's too romantic or something to think that like, oh, the AI is just going to be the key and you don't need these doctors now and you don't need the old way. You're outdated with your thinking. We can just like flip to this kind of impersonal approach and it'll just be great and it'll improve access for so many people. That's the argument you hear. But it's really so different than what we're trained to do as healthcare providers and what we aim for with the patients that we care about that are under our care. I guess the care part just seems to be missing out of the whole thing. And the care part's like huge. In fact, they've done studies that show that the provider-patient relationship is therapeutic if the provider cares about the patient and the provider, just the provider being on that patient's team improves the patient's health because the patient feels more secure about their health and maybe does more things in their life to, enrich their health and share that with their provider. So they've done lots of studies on that the provider-patient relationship itself is therapeutic. So we're going to lose that if we go into this totally just impersonal, bot-regulated AI performed technical process instead of the art of medicine, which is really, it is an art and it's an art and a science.
But it makes me wonder, Dr. Cooper, okay, let's say they send you the drugs, even the compounded drugs, and you're on that for 6 months or 9 months. And then what?
What? What's
when
the
do
intuitive?
When do we know, is it working or is it not?
It's like most of them seem to be a subscription, like a monthly subscription where they give you the meds. Mainly, if you think about it, these are mostly like drug sale companies. These are mostly product companies. They're selling a product. Without that product, they wouldn't survive. So if they can't make money off of the products they're selling, they're not going to just be out there giving you medical advice. So they charge you a fee monthly that includes the product plus some level of interaction with either, I don't know what, because I haven't gone forward to see what it's like, but with some other bots, I guess, that either talk to you about your nutrition or talk to you about your, medication side effects. We don't really know what those are, but you check in with something. And usually it's like a once a month thing. But I don't know how they deal with if, like, what if a person said, "Oh, I'm having like palpitations," or "I'm having like repeated vomiting, and now I'm like lightheaded, and I have some severe pain." Like, I just don't know what it would do because it's operating kind of outside that patient's medical home. It's not, a patient has a medical home, which is like normally their primary care provider, if they have one, hopefully, and then specialist providers, and that team communicates normally. And so if you have a problem, you can page your doctor on call, you can send a message through their electronic portal, you can interact with their medical assistant and get good advice. And then if you are referred out, as I said, there's going to be some communication there. And that way you can quickly tell the patient, do this with your medication, go to the ER, do this. This is what I don't understand, how they are in the medical realm because they're prescribing medication, and they're treating a disease, but they act as though they're still in kind of like a diet product model, like selling protein powders or bars or collagen or something. So it's confusing to providers who are, like, say, obesity medicine certified and trained in their specialty, that keep up with all the research and that strive so much to help individualize their patient's treatment to what's exactly going on with that patient and selecting things that make the most sense for that patient, setting the follow-up schedules based on that patient's progress. So it's just so weird to apply a cookie cutter approach that's just like the same for everyone. It's like, it really is. It's kind of like a imprint, they're just giving everyone the same approach within a few different variations based on their AI model. But that's just not how patients and people are. We're all different.
So it makes me wonder, one of the reasons that the GLP-1s were invented in the first place is diabetes. And we've talked in the past that half the U.S. population is either diabetic or pre-diabetic. So with this particular telehealth company that you dealt with, were you even tested? Would you be tested for diabetes?
There was no test. There was just a question. Are you diabetic?
That is crazy.
Yeah, no
because,
test.
We talked about most people who are pre-diabetic don't know it. What, 80%?
Yeah, exactly.
Don't even know.
80 to 90% don't even know.
You're giving a drug that could potentially reverse that, but they're not even measuring it. So it says to me that weight loss is the only metric that they're going to look at and that patients or customers are going to look at.
And they're not even really looking at the weight, because you can plug in any weight. Look at me. I plugged in a weight that's not my weight. They didn't ask any question on that. So there isn't really, and since they didn't see me, they can't tell if I said I'm 400 pounds. It doesn't matter. So it's kind of weird.
Right.
Okay.
There's no responsibility there, really, on the patient end, because you could lie about anything.
Yeah. I guess I've got to play devil's advocate. I'm just hearing that maybe someone would say, well, I can't afford a Dr. Cooper. I can't afford to go to do X, Y, and Z. This is an affordable option, and it gives me access to these drugs. What would your response be to that?
Well, I would focus on, if you're going through a telehealth program, there are a couple that are reputable, that you want to make sure that they employ board certified obesity medicine providers, that they have that board certification in obesity medicine, and that you're actually interacting with a medical provider. It can be through a telehealth visit. And also, if there are no labs involved, that's kind of odd. Definitely, I wouldn't trust that. And if there's
because a basic lab is going to tell you whether you're diabetic or pre-diabetic,
or if you have cardiovascular disease, like if you have kidney disease, things that need to be considered. And so I think definitely, if there's no lab work, there's no interaction with an actual provider in a telehealth consult that's board certified. And I think Also, if there's, signing up for products, that's also a red flag. If this is selling you products like nutrition supplements and the medication that they're selling you directly from their company, that's a red flag. It's one thing if they want to link to some outside pharmacies for you to purchase from separately, but if they're profiting off of what they're prescribing to you, that whether it's a supplement or it's a medication, that's a red flag too, because then it tells you, oh, this is not a healthcare first company. This is a product first company.
Yeah.
And they're just tacking on the healthcare on the backside of that.
Yeah. It makes, there's a corollary with the financial industry. And that's one of the red flags that they always warn you against. If you're going to a financial advisor that makes a commission off selling you a particular product, that's kind of a red flag because you don't know whether they're recommending that because it's what you need or they're recommending it because they get a sweet commission from
That's
from
right.
that as
It's
well.
like a sales pitch,
Yeah.
Right.
Yeah.
Andrea, when you and I get our labs done every 3 or 4 months, it's so comprehensive in terms
Oh,
of our
it's
total
hu-
health.
It's huge.
How many, Dr. Cooper, how many different parameters are measured when we get our labs done? Just
Well-
so that we can compare this with
Yes.
that bot questionnaire.
Well, and it's like the two of you both have the cardiovascular risk and metabolic syndrome. So automatically we're checking that deep level of your lipid panel with the lipoprotein numbers, with the particle counts and all of that we're tracking. And that itself is a big panel. And Mark, you had the TMAO elevation. So we're going to be following up on that regularly.
That's the
Then-
gut one, right?
That's the gut microbiome.
And I just ordered my my super duper, what do you call them?
Probiotic.
Probiotics. Yeah.
Good.
Those are expensive.
I
by the way.
know they are, but
But
those
if
are
it's what I need, I'll do it.
yeah, and they're like medical grade, and so the problem with the probiotics is if you don't get those really high quality ones, they might not help at all. And then we test, of course, blood counts, and if you have iron deficiency, we're checking the iron
Right, I do
levels.
that.
Andrea, yeah, exactly. And then we're checking in our male patients, we're still checking testosterone and estrogen levels, even as you get older. In our female patients, once you're through menopause, we really don't check those often unless you're on hormone replacement therapy, then we might check. But then we're checking kidney function, liver function,
Right. I
and
do all those.
blood counts, stress hormones.
It's a
And-
lot of pokes.
It is. And in addition to that, it depends on also once we get through the Medicare age group, we do pare it down a bit because if we have long-term patients, we kind of know their system and the out-of-pocket costs can go up a little bit. So we try to keep cost conscious, especially with Medicare patients. But we would like to look at things like leptin, which is that body fat hormone, and occasionally we look at other neurotransmitters of famine signals. And we don't do it every time, but we're trying to figure out if it's moving the needle enough. The medical therapy and the lifestyle strategies our patients are doing, is that moving the needle enough to get the patients to a point where they might eventually become less dependent on medication, even though that's not necessarily the goal, but it's nice if we can get to a point where the body strengthens itself enough to take over a lot of what the medication has been doing.
Well, it's an interesting map that you create and a chart that for me, I mean, it's, over a decade's worth of information that's total fact.
Yeah,
I mean, you
it's the
can't
data.
mess it up. It's data that you can see, oh, look, this changed, this changed, this changed. And then you've used it to adjust medication up, down, sideways, whatever you've done. And we've, made adjustments to make things work better, to make my health healthier.
Yeah, I mean,
Healthier?
yeah, and I can't stress enough how great that is to have. So that's one area where it's a good use of technology in medicine is to create these database where you can see your patient outcome data. Because we not having that technology in the past, years and years ago, really it was a disadvantage because you cannot see those trajectories that patients are on. Where is their health? Where was it? Where is it going? Where is it going to be if we don't make a change? And now with the database like that and the display that we get with looking at over time the changes, and now we have with medication, it's integrated into it, so you can kind of see when medications were changed, whether there was an effect, negative or positive, and when different life events happen. Also, like our patients will say,
Right.
"Oh my gosh, that's when." My father died and something
Right.
traumatic happened, and that's where the stress hormones were like thrown off. But you can track a lot of these things that way, and you can track in a snapshot what your progress is since day one in all these various areas of the risks, which would be cardiovascular risk, metabolic risk, liver fat markers, and diabetes markers, and the weight markers, and things like that. And, and body composition. And so having technology and using it for good to enhance the quality of care, I think it's essential. We
But I
need it.
think that, let me interrupt for 1 second. I think that that's where your intuition comes into play, as opposed to where just like some robot could, an AI could diagnose that.
Yeah. I mean, you could then take that data and then ask AI to look into this more further and provide more valuable information coming out of it. But that's certainly not what what
That's
they're
not what's
doing.
but I don't think
No,
that's what's happening
no,
in these things.
no.
I think that like you said, there are some very good
Yes,
programs out there,
there are.
but I think that what a lot of the mass market, let's just say the mass market ones, they're very transactional. And like Mark said, for some people, they may be helpful, but I do hope that some of the people who are using them as transactional are also seeing a good doctor along with it, because I do think that it's just not a great idea in terms of your overall health. Like, I think it becomes something that is just transactional, and in the long run, you're just going to be disappointed because it's not going to be a good idea.
I think one thing we should touch on before we wrap things up. I was watching the national news last night, and a new study just came out about
liver.
another benefit
The fatty liver.
of the GLP-1s, and that is to treat the fatty liver. And it seems like, Dr. Cooper, that the fact that these drugs seem to be really safe. We now have millions of people on these drugs, and now we're finding that it's lowering the risk of not only diabetes but heart disease and liver disease, and the list just keeps getting bigger and bigger of the benefits. And I think maybe that's playing into this scenario of prescribing this stuff as much as you can,
Yeah.
because
Right.
it has such
It's true.
profound impacts.
Yeah.
If it weren't as safe as it is, we probably would be telling a different story, right?
Right.
And there would be some more oversight.
Yeah, I think so. Maybe it's true. I mean, eventually, because of our environment, that with the endocrine disruptors and all that stuff, maybe someday we'll all need to take these drugs.
It's
But
probably, you're right. I mean, I'm a fatty liver success story.
yeah, and it's true. It's just like I think people just think, well, there's no harm in it. There can't be any harm. But I feel like we're the companies that we've talked about that have the impersonal approach, not the high quality companies that are board certified obesity medicine doctors and things, but the other ones that are cropping up everywhere selling all the compounded meds. Those companies are relying on the medication to be almost like the doctor. It's like they give all the power to this one medicine to like take care of all your problems.
Right.
And
You got
I-
other problems.
yeah, and I really, I mean, these medicines are amazing, but they are not that powerful. I mean, and when Andrea says people will be disappointed, in the short term, they won't. Most,
Right.
I mean, not some of them will, but I think if you look at the vast majority of people over the short term, they'll feel like, wow, this is great. Even if they
Miracle.
have the impersonal care and they receive these, it's more that this is, if you think about it, obesity is a chronic disease and it's not something that reverses overnight. But people are so used to the diet model that they're used to having these, short-term results that are amazing, and then it stops, and then something goes wrong. So it's being sold to them in that context. So I think that the level of disappointment when things don't seem to be going the way that they anticipated, it won't be the same as if it hadn't been sold to them as like this diety model. I think people are so used to that, but there's still disappointment. I mean, look, even patients who receive the best care, we talked about it in another episode, our own patients, people who receive the best care, there is a subset of people who are extremely resistant to everything that we can offer them, in spite of all the high-level lab testing and them working so hard on all of their lifestyle strategies of sleep and regular nutrition and fueling their exercise and all of this. And they're just dealt, a bad hand genetically. And so there'll be people like that everywhere. But if we're seeing that group, even with that higher level quality care, there's going to be a lot, a lot missed when you just are relying on an impersonal approach and a single medicine just throwing at you just based on your BMI. I think that's going to be, as Andrea said, disappointing in the long run for quite a few people.
Well, I think this has been a really interesting discussion. As we wrap things up, final comments from the panel, Andrea?
I would say just find yourself a really good doctor if you can. I mean, it really is the best way to go. I know it's hard for some people, but really try. Really try.
All right, Dr. Cooper.
Well, I think in the show notes, we'll post a couple of organizations that I know of that have nationwide telehealth that are reputable, with obesity medicine certified practitioners and people at the helm who are doctors who care about how this is delivered. So I'll post those in the show notes so that people have a reference, because I know we have listeners from all over the country, and they have clinics but they're all through telehealth mostly. I think it's primarily telehealth, but they have sites all throughout the country. And so that is a good place to check for higher quality telehealth care.
Okay. I guess the biggest takeaway for me is that telehealth is not the problem. It's actually the solution for a lot of us. But the thing that you really said, Dr. Cooper, that's sticking out in my mind are the red flags. If you don't get to see your doctor face-to-face and talk with your provider face-to-face, that's a red flag. And also, if you're not being measured, if your metrics aren't being measured, like whether you have diabetes or whether you have cholesterol problems, if there's no measurement of that and there's simply a transaction, that seems to be another red flag. So I really appreciate the conversation, because this is, as Andrea says, follow the money.
Yeah.
And this is a booming industry.
It's the future.
Yes.
Yeah. All right. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.